Thanks, Laura. Hello, everyone, and welcome again to our broadcast. I'd like to thank you for joining us today for our presentation of the key telemedicine trends identified by our 2016 Telemedicine Industry Benchmark Survey. The practice of telemedicine is evolving rapidly, with hospitals offering a growing number of services and frequent regulatory updates announced. Though the industry is still young, there are some patterns that have emerged related to program objectives, challenges, management structure, and decision-making. We look forward to a robust discussion between telemedicine industry experts. For those of you that may not be familiar with Reach Health, I'd like to provide a brief introduction. Here at Reach Health, we provide enterprise telemedicine software that supports the unique requirements of each medical specialty in multiple settings of care, all on one reliable software platform, Reach 5.0. This browser-based telemedicine platform runs on a variety of clinical endpoints, including carts, personal computers, and tablets such as the iPad, whatever device works best for the specialty and setting of care. Reach 5.0 also enables bedside physicians to actively participate as they conduct joint examinations with remote specialists. Consultations in Reach 5.0 are facilitated by Reach Clinical Widgets. Clinical widgets are the building blocks for telemedicine consultations. These patent-pending configurable apps support each key function in a telemedicine consultation. Clinical widgets perform a wide variety of clinical functions, including patient data collection, access to labs and images, disease-specific exams, and others. This slide shows an example of clinical widgets that could be used for behavioral health teleconsults. You'll notice that some of the clinical widgets, such as vital signs, are applicable to multiple specialties and care settings. Others, such as a psychiatric treatment plan, are applicable only to one specialty. By grouping widgets together, you can define service lines, each with a unique clinical workflow. Additionally, each physician can choose desired widgets to further refine workflows to suit their patient engagement preferences. Throughout the care continuum, information is downloaded from and uploaded to local and remote EMR systems, providing each physician with a complete view of the patient's treatment history while eliminating the overhead of dual data entry. Before we begin the discussion, I'd like to remind everyone to submit your questions at any time using the webinar questions panel on the right side of your screen. If your webinar panel is minimized, you can use the orange arrow at the top to expand it as needed. We'll take as many questions as we can at the end of the presentations. Before I introduce the presenters, I'd like to ask you to participate in our first audience polling question. This will help the presenters understand the telemedicine experience level of the audience. Which telemedicine models does your program support? Please select all that apply. Choose A, consumers connect directly with patients. B, clinicians and their patients connect with specialists. C, peer-to-peer consultations such as ED to ED. D, continuous patient monitoring such as the ICU. And pick E for NA or not sure. With that, I'd like to introduce our three panelists for this webinar broadcast. Scott McLeod is the Vice President of Marketing for Reach Health and one of the co-authors of the 2016 Telemedicine Industry Benchmark Report. Bill Bowling is a seasoned healthcare attorney who is the owner and principal of Bowling & Company. Mason Reed is an associate with Bowling & Company. Thanks for joining us, gentlemen.
Glad to be with you.
Yeah, thanks, Andrew. Hi, everyone. This is Scott McLeod here, and we'll go ahead and get kicked off and dive into some of the survey results. So on your screen here, you're seeing a little bit about the demographics of those that participated with us. This year we had 390 participants, which actually represents a significant increase of 67% over the participation from last year. Probably an indication of the growing prevalence of telemedicine. And for any of those of you that were participated in the survey with us, I want to thank you very much for your participation. It was a very detailed survey, and we very much appreciate your input. You'll see on the screen that we had a wide variety of participation, predominated though by the larger hospitals and health systems, and then within those predominated largely by teaching institutions. Okay, if we look at the at telemedicine as a priority amongst the participants, you'll see represented by the blue and green pie slices that about 66%, almost two-thirds, said that telemedicine was a high priority or the top priority in the healthcare organization. I should also note, too, that of the participants, only about 10% of those were reach customers.
Thanks, Scott. We'd now like to look at telemedicine maturity.
Correct. So we, in the survey, we asked a couple of questions about maturity related to two different metrics. The first you see here is the metric that represents maturity based on service lines. And as you can see, some of these represent a much higher degree of maturity than others. And in fact, all of those 7 above the red line indicate service lines or specialties where there are more active telemedicine programs than there are programs that are being planned or implemented. And then below the red line, interestingly enough, we see a flip-flop where the maturity levels are much lower, where we see a higher degree of planning or implementing than we do active telemedicine programs. And those above the line, as you can see, are predominated by specialties and service lines that are, in higher acuity or emergency situations for the most part.
Bill, Mason, have you seen any changes or any trends in the maturity based on service line?
This is Bill Bowling. Thanks, Scott and Andrew. The trends that are being shown in your graph, I think, are consistent with what we have seen. I was fortunate to be with Dr. Hess when he first pioneered Reach Health at MCG in the 2003 range. And telestroke, for obvious reasons, has such a high value and high impact. It's not surprising to see this more fully developed. I think chronic disease management and subspecialties are all beginning to come on board. We're seeing more with infectious disease specialists and specialties that are in high demand and low supply are particularly coming on board now. We're working with someone who has a really wonderful program with women's health and telemedicine, and I think we're probably still in an adolescent stage of telemedicine's spread and development, but definitely growing rapidly.
Thank you.
All right, folks, so let's look at the other measure of maturity. In this one, we focused on settings of care. And you'll see, again, we see an interesting division line, a flip-flop between those programs that are active, more so than implementing or planning, or below the red line, those that are more prevalent in the implementing and planning stages, and fewer that are active. And once again, just like before, those above the red line, predominantly in the high acuity or the emergency settings.
Thank you, Scott. It's now time for our second audience polling question, and I'd like to ask everyone to again participate, please. Which best describes your organization's approach to telemedicine? Please select only one. One platform for multiple specialties or care settings, that's A. B, several platforms for multiple specialties or care settings. C, for each specialty or care setting uses a separate platform. D, if you only support one specialty or care setting, or please choose E for NA or not sure. Thanks again for participating.
Here we're looking at our enterprise telemedicine comparison, a trend comparison, and you can see that the number of service lines being implemented in these organizations is growing rapidly. 19% for health systems year over year, 15% for hospitals. So, and Andrew, I believe Bill and Mason may have something here as well.
Yes, sir. Bill and Mason, have you seen any trends here, perhaps decision makers changing?
Yes, this is Bill again, and Mason will chime in, I'm sure. But one of the areas we're being engaged increasingly with is as health systems are becoming more. For example, a tertiary care center that one of them that we're working with has added 2 new hospitals, community hospitals that are now part of their network. So they have an imbalance of specialists at the mothership, and one of the opportunities for the community hospitals is to have access. Ease of access and greater access to those specialists and subspecialists that are back at the home of the tertiary care center. So hospitals, you can shuttle human beings back and forth, and you can do that to a certain limited extent. But if you can really use telemedicine to make important linkages to support the medical staffs at the community hospitals and to provide access to some specialists and specialty follow-up at the remote facilities, that's really a great way of enhancing the value of that system to the hospital. Another tertiary care center that we've worked with and others that we're familiar with is using telemedicine to augment their connectivity to the public schools and to other larger patient population groups that can get more convenience and better access. And for those types of larger programs, that's frequently being taken. A single hospital, certainly even a single community hospital, can do it. We're in conversations with one now about that prospect, but often it's the larger systems that can leverage their assets very effectively through telemedicine.
Thank you very much, Bill. Let's take a look at objectives and success factors.
Great, thanks, Andrew. So, folks, this is a fairly complicated chart, so let me take a moment to orient you to it. So we asked the participants about their program objectives, and you can see the dark blue bars indicate an objective as their top objective in telemedicine or a very high one. The green indicates medium or low priority, and then the light blue indicating not a priority. And one very interesting takeaway that we see here is that all of the top 4 objectives for the participants are outwardly oriented, in fact, patient oriented. So improving patient outcomes, improving patient convenience, engagement and satisfaction, as well as access to specialists. And we found this fascinating and encouraging as well to see that all of these objectives are outward and patient facing rather than inward oriented, and those are obviously some of the lower priority objectives. Okay, so along similar lines then, we asked about their success in achieving the objectives. And again, in this chart, I'll walk you through it real quickly. The dark blue bars indicate that they feel like they have been highly successful in achieving their top objectives. Green indicating moderate success achieving their top objectives, and then the light blue thus far unsuccessful. And interestingly enough, too, then we looked at this and said, okay, well, relative to the top objectives, where do they fall in this success? And you'll see that I think it's a good sign that of the top 3 objectives from the prior chart, they're all very high on this list, meaning hospitals feel like they're achieving a high degree of success relative to their top objectives.
Bill and Mason, how about you? What have you seen in this department?
Hey everybody, this is Mason. Yeah, I think it's interesting how often the word patient appears there in those top few objectives and in the success factors as well. It's no secret that telemedicine aligns very nicely with population health management, and getting frequent contact with patients, better contact with patients in and outside of the facility. We've seen when a provider is really making a serious effort toward population health management, their telemedicine interest sort of correlates with that. So, and also, payers are going to be similarly aligned there, and so we expect to see more accommodations like we've seen from Medicare with the next generation ACO model, from private payers. They're wanting to save money. Telemedicine helps that, and it just makes a lot of sense.
All right, so one of the other things that we did relative to success is that we pulled together some correlations. We examined various telemedicine program attributes for correlations to success and failure. Now, can we state that these attributes have a direct impact on success? Well, we can't say that scientifically, but we can tell you that all of these correlations are statistically valid, which to us indicates that there is probably a direct impact on success. The first one that we're looking at here is fairly obvious, self-explanatory. Basically, we correlated program priority with success. And what you can see in that chart is that in organizations where telemedicine programs are ranked as the top priority, they're 62% more likely to be highly successful than in organizations where telemedicine is ranked as a low priority. So, you know, we're kind of stating the obvious here, but you can see it in black and white, or at least blue and green. You know, prioritization of the telemedicine program does have an impact. Okay, so the next area that we looked at to correlate with success is the degree of focus of the telemedicine. Sometimes they're called program manager, sometimes program coordinator. And what you can see here is that if the telemedicine program manager or coordinator is dedicated to the program versus only partially focused, the program's 43% more likely to be successful. Then we also took another look and said, what about program manager level? And I find this very interesting, is what you can see in these charts is that the degree of focus of that program manager is much more important, much more influential on the success than the title of that program manager. And we hear this anecdotally from a lot of the hospitals that we work with.
Thanks, Scott. Bill and Mason, what have you seen with regard to program managers and perhaps the success of those programs?
Well, your results track, perfectly with what we see, which is that if your institution is not prepared to really assign a high priority to it, that it's not just going to happen. And typically, if you've assigned a high priority to and a strategic value to your telemedicine efforts, then you will probably have a dedicated program manager. And if you do have a dedicated driver who is effective and can rally one or two champions, then I won't say it's guaranteed that you will succeed, but you have a very high probability of success. But without a dedicated coordinator or program manager, and she or he does not have to be brought in from the outside. It can be someone that's within the team that already has the right relationships, the right skill sets, and an interest in this, and they can, and in some ways, could be more effective than someone from outside, but they've got to be focused on it, and they've got to be a true champion. And that's interesting that your poll results demonstrate what we've seen repeatedly.
Thank you.
Yeah, that's very interesting. In fact, we are aware of one program using REACH that I think they would have classified themselves as moderately successful during the period at which they did not have a dedicated program manager. And once they put that program manager in place, focused on the program full time, the performance of that program improved significantly, and they attribute it to that one particular change. Okay, so another correlation that we examined was related to funding or budgeting of the program. And, not surprisingly, those programs that indicated that they had adequate funding are coming in at more successful than those that are, partially funded, or their funding challenges were partially addressed. But relative to that too, or close to that, we also looked at level of executive support. Again, programs that said they have full executive support, or maybe it had been a challenge and they've addressed it, compared to those that don't. What I find fascinating here is that the level of executive support seems to be more important than the budget. And what that tells us, and in fact, that's by a 2-to-1 difference in the gap between high degree of success and unsuccessful. And so what that tells us is basically you need support, but you don't necessarily have to break the bank in order to implement a telemedicine program.
So we've talked a little bit about success factors. Now let's take a look at telemedicine program challenges.
All right, so another fairly busy chart here. Let me orient everyone again. The blue bars to the left indicating challenges that remain unaddressed. The light green bars indicate challenges that have only been partially addressed. The light blue indicating challenges that did exist, but they have now been fully addressed. And finally, the light green on the far right indicating just not a challenge at all. And so if we find this fascinating and consistent with other data that we see in the industry today, the top 3 challenges in telemedicine here are all related to reimbursement, both government and private. So clearly that continues to be probably the top challenge that's industry-wide for telemedicine. Now moving down from reimbursement, you'll see that 3 of the next 4 of the top challenges are all related to EMR systems. We find that fascinating, and we'll drill into that in a little bit more detail in just a moment. Then mixed in there as well is the struggle to determine the ROI of the telemedicine program. I have a feeling that that's probably tightly linked to those reimbursement challenges up at the top. And then moving down a little bit, it's interesting that physician compensation is in that upper half of the top challenges, but fortunately physician acceptance looks like it has largely been abated as a challenge. So my guess is the physicians themselves are not challenged. It's the organization running the telemedicine program and trying to determine how to iron out the details of physician compensation. And the last thing I want to point to here is also very encouraging, and that's amidst all of these other challenges, patient acceptance itself is very low on the list, which is a good sign in the industry, and anecdotally we've seen that improving quite a bit in recent years.
Thanks, Scott. Bill and Mason, what types of challenges do your clients typically encounter, or what types of challenges are you frequently called in to help them resolve?
Yeah, this is Mason. I'll start with a note on reimbursement, and then Bill may have some thoughts too. We certainly understand not all environments, not all payer environments are the same. It varies by state. And if you are a provider who's experiencing reimbursement difficulties, we feel your pain. Now, having said that, we do think that, for those who haven't fully embraced telemedicine yet, that the perception of reimbursement might be worse than the reality. We're fortunate to be in a state, Georgia, with a parity law, and parity laws are increasingly being adopted from state to state. I think since 2014, at least 8 additional states have added on. There's something like 30 total now, Arizona being a recent one. So that really helps. And if you've got that kind of law behind you, make sure you're using it, make sure you're challenging payers if they're not complying with it. We've seen organizations who are just doing great with reimbursement because they've struck up the right contracts and they're really doing well. Now, again, there's a long way to go. Medicare has a long way to go. We understand that, but we do think that especially if you're in a state that is friendly to telemedicine, that reimbursement can be your friend.
I would just add to that I think some of the challenges around reimbursement are really more related to organizational inertia, and it's not to point the finger because it's always very difficult. You know how to do your revenue and billing cycle. Your directors and your provider lines know how to interact with your back office. It's just that suddenly now you have a new environment where care is occurring, and it just takes a little while for everyone to get on the same page about how that can be coded and reimbursed and tracked and kept in the in your EMR. So what I call revenue cycle and back office functionality is almost like a new animal in the barnyard that everyone has to be really devoted to understanding how are we going to get reimbursed by this. So as much as it's maybe sometimes the legal environment really in many states, and most states even, is very favorable for reimbursement, but it's just getting your own team on the same page where we can do this, we can get reimbursed, and here's how we're going to do it. So that's when consultants or law firms or others can come in and provide that outside expertise sometimes and a nudge to your own internal team to overcome that inertia.
Thanks, gentlemen. Let's continue the discussion on challenges.
Yeah, and in fact, I promised a little bit more detail on challenges related to EMR systems. And find this fascinating that, again, we look at the blue bars indicating challenges unaddressed, green partially addressed, light blue fully addressed, and you can just visually you can see the blue bars are significantly larger than the light blue. Dark blue is larger than light blue by a factor of more than 2 to 1. So these these areas are lack of native capabilities in the EMR systems, lack of integration with EMR systems, and lack of common EMRs when multiple hospitals are working together. So I think in our areas where we were focusing on maturity, although we didn't see this specifically in the results, and I'm guessing we didn't ask the question in that question about EMR systems in those results, to me this indicates a high degree of immaturity still in the industry. And in fact, if you look at how EMR systems are being used relative to telemedicine, this is fairly interesting as well. So for our survey participants, only 12% indicated that they were using their EMR system as their telemedicine platform. Only 27% indicated that they were using a telemedicine platform and have it connected to their EMR system. And the majority, almost 2/3 of the participants, indicated that they have a telemedicine platform and it's not connected at all to the EMR system, which from our perspective tells us that these organizations are seeing the opportunities and the value of telemedicine and realizing that ideally they probably like to be able to connect this into the EMR for efficiency purposes. But in spite of the fact that that's, in many ways, for many organizations, not practical today, they're moving ahead with telemedicine anyway as these linkages catch up.
Let's take a look at telemedicine program return on investment contributors.
Great. So here's a list of the ROI contributors that we asked our participants about, and again, find it fascinating that. At the top of the list is improved patient satisfaction by a very wide margin, right? 53%, the closest is at 38%. Find this fascinating, again, that often I think in many organizations, ROI measures all center around dollars and cents, logically. This doesn't look like this would often be called a soft contributor to ROI in many organizations as opposed to a hard contributor, either driving higher revenues or reducing costs. But many healthcare organizations are seeing this as a significant contributor. And closely behind there, again, another patient-related one relative to improved reputation, externally focused versus internally focused.
Thanks, Scott. Bill, Mason, do you have any thoughts on any of these ROI contributors? Maybe reputation or perhaps the hospital's capabilities?
Well, I think it's highly dependent on the particular market and the particular organization. But if you're in a market like many of our hospital clients are, where you're competing with other health systems, and you're a first mover or an early mover or a most effective mover with providing, everyone has an iPhone now or smartphone, and they're getting so much of their services and so much of their information through that device. if you can provide an effective linkage between your patients and, say, in a pediatric setting, the parents, say the child's at school, man, it is just I think a PR bonanza in terms of word of mouth, in terms of stickiness with your patient population. So I think in a highly competitive market, I think the soft ROI contributors may be of greatest value right now. I also think that as an early mover or most effective early mover, you're going to find that with clinically integrated networks, with ACOs, or whatever other method you're using to manage patient population, you're going to be having better outcomes, and you're going to be more attractive when you're in negotiations with payers or other large patient groups. So you can wait until, you can always adopt things too early, and you can adopt them too late. I would say with telemedicine, even if you have a rudimentary program, now might be the time to look at expanding it so that you're ready over the next 2 or 3 year cycle to be ready to leverage it for your patients, and also linkages among your providers.
Thank you very much, Bill. That was a very detailed answer. All right. It is, and also just thank you in general for a very insightful discussion, and I'd like to ask everyone to participate in our third and final polling question, please. Would you like to learn how Reach Health or Bowling & Company can assist with your telemedicine program? Please select A, yes, telemedicine solutions from Reach Health. Select B for services from Bowling & Company. Select C for not now, but possibly in the future. And please select D for not interested in learning more at this time, and you can select more than one option. All right, everyone. Now it's time for our question and answer session. We've received a lot of good questions during the broadcast. Please continue to send them if they arise. Let's start with this first one here. We've got this question asked a lot. It's basically people want to know if they can get the copy of the slides or the recording. The answer is yes. We're going to send those out within 3 to 5 business days. We included the full, if you haven't read the report itself, the industry benchmark report, we included that as one of the handouts, which are located to the right of your screen in the webinar panel. If it's not working for you, you'd like a copy of it, we're going to show a slide in a little bit that tells you where you can get it. So let's get into another question. It seems like the terms telemedicine and telehealth are used interchangeably. Is there a difference? I'll direct that one to Scott.
All right, thanks, Andrew. Yeah, that's a great question. Not surprised at all to see that. We hear it a lot. And in fact, just Monday, I read a lengthy article on this topic. The article included input from the American Telemedicine Association, from HIMSS, from Health and Human Services, and Center for Connected Health Policy, and I think some other organizations. And ATA's stance on this was interesting. They basically said these are interchangeable. They basically mean the same thing. But as you drilled into the details, there were a couple of consistently noticeable differences. One, in fact, was that telehealth is generally regarded as broader than telemedicine. So telehealth includes things like education and training, where, on the other hand, telemedicine is really focused on, patient treatment and engagement. And I've recently heard a great expression of the difference between the two, and in fact, it was included in that article as well. And it said, when you think about, a patient going online and paying $30 to consult with a doctor to try to get, let's say, diagnosed for a sinus infection and get a prescription. That's what we call direct-to-consumer, and that's really what you think of when you think of telehealth. Telemedicine, on the other hand, would be a patient, an example of it would be a patient, say, going into a clinic, and maybe they've got chest pain, and the clinicians there, they don't have a cardiologist on staff, and they're not really versed in diagnosing, a complex cardiology situation, and so they would then connect with a specialist remotely and have them join, and the remote cardiologist, the specialist, and the bedside clinician would then collaborate through telemedicine to diagnose and treat the patient. So I think that's a great definition and great examples of the differences between telemedicine and telehealth. I mentioned that article, by the way. If anyone would like a link to that, in fact, the person that asked this will be sure to send them the link. But if anyone else would like the link to that article, just submit a question real quickly, letting us know, and we'll be happy to send that link to you after the webcast.
Thanks, Scott. It's interesting. You mentioned the clinician who was in the clinic, didn't have expertise in cardiology. I've heard that person called the patient presenter sometimes.
Oh, interesting. Very good.
All right, moving on. Here's another question. You mentioned a trend towards an enterprise telemedicine approach. Can you offer examples of how hospitals are managing the change?
Okay, yeah, thanks, Andrew. I'll tackle that, and yeah, that's another great question. So basically, what we're seeing is a lot of healthcare organizations started their telemedicine program with one service line. It might have been telestroke. It might have been focused on behavioral health. It might have been focused on continuous monitoring in the ICU, something like that. And they kind of learned the ropes with that one program, and most likely, have had success and proven the value. So, but then some organizations, it kind of became the Wild West, where one group put up a telestroke program, another group put up a behavioral health program, and so on, and they might have done it in completely different ways, not connected at all, different platforms and so on. So when we talk about enterprise telemedicine, what we're talking about is looking at ways to say, hey, can I have one telemedicine platform and start to spool up all of these different service lines and maybe even settings of care, like putting things in the clinic for follow-up care and so on. And so what we're seeing are two things happening very commonly now. Either the hospital will establish what you might call a telemedicine czar, which is one person that has oversight over all of the telemedicine programs, regardless of the specialty or setting of care, or they'll set up a committee even that does the same thing. And so if somebody then has an idea for another way to use telemedicine, they go to the telemedicine czar, or they go to the committee, and they basically make a pitch for it, and then gain approval through a standardized process to add their specialty into the growing program that they already have, with the objective of trying to keep vendors to a minimum, keep platforms to a minimum, and keep complexity to a minimum, quite frankly, leveraging the success that's already been established with the platforms that they have in place. And so this is very common. We're seeing it more and more right now. So hopefully I answered the question about how hospitals are managing the process, the change.
Thanks, Scott. And we've got a related question here. I'd love to hear your take on this, Bill and Mason. And the question is, how do the challenges for fledgling telemedicine programs compare to those of more mature programs?
That's a great question. I think in some ways there's greater opportunity and greater challenge for the new initiator of a telemedicine program. The greater opportunity is that you don't have any legacy or anything to undo, so you're starting from scratch, and you can adopt best practices, and you can begin your program with a 2016 attitude about knowing that you want to build a foundation that you can expand on. I think the greater challenge for a new initiator is getting the key leaders in the organization to understand the value proposition and to have buy-in from the IT department, the medical staff, and the service lines that are going to be engaged in the first phase of it. For a large provider, the issue is, well, you probably perhaps have done episodic or scattershot approaches to telemedicine. People fall in love with their own best of breed, and they don't necessarily want to let go of that to move to something that's going to be more enterprise-oriented. And so overcoming kind of the piecemeal or the Tower of Babel problem in a larger organization can be a challenge. But again, it goes back to, in both instances, it goes back to your chart that showed that if it's made a top priority and senior management places enough emphasis on it to give a program coordinator or a czar who's going to be working on this as a matter of unique and sole focus, then on both sides you can overcome this. For me personally, I'm more excited by a new initiator because it's just really great for the patients and the system to get the experience of making everyone's life better. That to me is, I prefer that. I like both kinds of engagements, but I think it's just exciting to be a first-timer.
That was a great answer. Thank you. All right, so here's another question we received. It says, you mentioned determining ROI as one of the persistent challenges. Can you share any techniques that others are using to measure ROI?
Wow, yeah, that's a, boy, that could probably be a webinar topic unto itself, quite frankly. But a couple of quick thoughts during our Q&A here. ROI is almost assuredly going to be linked to the area that your program is focusing on. So if you've got an enterprise program, you're probably going to have multiple ROIs. You might have one specific to stroke. In fact, you might even have one specific to emergency stroke and another that's specific to follow-up stroke care. The same for behavioral health and other specialties. So you really have to drill down into the intricacies of each of those specialties and settings of care and determine what is it you're trying to accomplish with that in the first place, and then how you're going about it. So to not totally avoid giving you a specific answer, we've actually co-developed a case study with one of our hospital customers on the ROI that they measured. It's very detailed. We'd be happy to send this out to you. So it happens to be on emergency telestroke in a hub and spoke network. But so if you're thinking along those lines, it could be a great example for you to use. But even if you're not, if you're thinking, say, behavioral health in a clinic setting, it can still give you some ideas, maybe some techniques to use. So again, everyone, if you want, send in another quick question and let us know if you'd like the ROI case study sent to you, and we'd be more than happy to send that to you as well after the conference.
Thanks, Scott. And then just out of curiosity, Bill and Mason, what have you seen in this arena? Do you have any suggestions on how they can measure ROI?
No, I think there are a lot of qualitative factors that go into it, and I think each health system will set a higher priority or have a little bit different formula or algorithm for the softer elements of it. But for tertiary care and larger health systems, they should have no difficulty with their CIO and their C-suite team developing, using whatever their usual method is, a swag for how this will play out. I think another, and you alluded to it a little bit, another challenge is that you're trying to skate to where the puck is going to be, right? So if you're assuming that things are static and that the effects of the Affordable Care Act are going to be the same 3 years out as they are in 2016, then that's just not correct. Things are moving very rapidly in terms of the importance of clinically integrated networks. And so the size of your organization and where you see yourself vis-a-vis your payers and your competitors will affect pretty dramatically what your ROI is. It's more complex than it used to be. So good luck.
Thank you very much, Bill. You know, it occurs to me, this is something I've heard from our customers before. Sometimes when they are partnering with smaller spoke hospitals, there's a little bit of hesitation because those spoke hospitals are concerned that they're going to lose all of their patients, right? They're going to have to transfer all of their patients to the hub. And so when the hub hospitals are able to show, no, look, we're taking the most severely ill patients and we're leaving the rest of the patients so they can be at home in their communities. It's not really the same thing as a return on investment, but it's showing the spoke hospitals that they're not giving up treating all these patients, which, you know, in reality is also a revenue opportunity.
Right, right. It's a good point, Andrew, because it turns into a real win-win-win. A win for the patients because they stay in the local community, treated close to home. The spoke hospitals end up actually keeping more patients than they transfer, and the hub hospital ends up taking the patients that rightfully should be there, the more severe cases.
Mm-hmm. So Bill and Mason, I've seen some of your presentations before. I think this one is good for you. It says, reimbursement is an ongoing concern. We've talked about that in the broadcast a little bit. How quickly do you think we're moving towards true parity?
Mason, you want to take a crack at that one?
Yeah, it's hard to say. Of course, you know, we don't have a crystal ball, but I think it is very rapid. I think you know, within the next 5 years, Medicare will have removed many of the geographic restrictions. You know, they're trying to gauge, well, is this actually leading to better utilization, or is it actually leading to overutilization? And I think as telemedicine is deployed with population health in mind and value-based care in mind, it's going to become very clear to everyone just how much money can be saved with early intervention, with education, with those kind of things. I just, you know, I'm a fairly young attorney, and I haven't been doing this for more than 5 years, and I've seen in just tracking the regulations, tracking the reimbursement. I've just seen so much change even within that time. I think this isn't directly reimbursement, but if you look at what's happening with the Interstate Medical Licensure Compact and other licensure developments, with states accommodating through their medical boards, creating fewer barriers to, in most cases, creating fewer barriers to a telemedicine encounter, you're just seeing these different roadblocks falling one by one, and I really do think 3 to 5 years is going to look a lot different than it does today.
Thanks, Mason. We've got another question here. It says, at what point in the planning process should you bring in and or hire a telemedicine coordinator?
Thanks, Andrew. That's a very interesting question. You know, we spoke earlier about the importance of having a dedicated program coordinator. We see anecdotally that the earlier, I mean, the simple answer is the earlier the better, as early as you possibly can. Now, a lot of organizations, for cost reasons, will attempt to go without a program coordinator or dedicated coordinator as long as they can, and I think they risk pinching pennies and losing dollars, quite frankly, because that person gives you a point of accountability from the beginning, even if they're not directly responsible for all of those early stage activities. A great example would be if you're setting up a hub and spoke network. Spoke recruiting is going to be very important. That coordinator may do that recruiting directly, or may not have the skill set that you want, but will shepherd the person who is responsible and help to keep them on track and raise visibility if things get off track, so that the problems can be dealt with early rather than late when they're less painful. So again, earlier rather than later.
Thanks, Scott. If I could, this is Bill Bowling. If I could add one other idea, and I totally agree with what you said on earlier, the earlier the better. The other thing I would add, which I was a general counsel for many years, and so I learned instinctively that you need to avoid hiring a consultant or someone from outside the drop of a hat. You can pave your way to the poorhouse with consultants, but I would say in telemedicine especially, that if you can bring in the right size consult in this area, once you've determined internally that this is an avenue that you'd like to pursue, then that organization or those people can help you understand, well, who within your organization, and it varies from hospital to health system, who is the right person. But you can often, as part of the process of vetting, well, what might we do if we did something? And this is our favorite kind of engagement. We've done a lot of these. Well, who are the champions that emerge there, and who might make an ideal early coordinator? So I would give that some thought as well.
That's a great point, Bill. I'll just say this is somewhat anecdotal, but Scott brought up the concept of skill sets. It's hard to say exactly what the full skill set should be. Obviously, some clinical experience is going to help, but one that is going to be absolutely critical to the long-term success of the program, I think, is a mind for data and analytics, because you're going to have one, this person is going to need to report on the success of the program so far, which may have been grant funded, in many cases is going to be grant funded, and is going to be going back to the executive team saying, so here's what we've done so far. We don't have grants anymore. Now we need to put more skin in the game, but here's what we get when we do that. And then also just that same set of skills is valuable for being able to look at individual hospitals in the network and individual providers that are conducting the consults to say, keep doing these things, do more of this other thing, and maybe back off on this a little bit. Anyway, hope that answered the question. So we received another question, and this one says, does the hardware factor in on telemedicine success? Do you want to take a stab at that one, Scott?
Yes, I'll take a stab at that. A very interesting question, and so going back to success factors, and it's not something that we pulled on in the survey, but anecdotally, we actually have a lot of data on this. Answer is a bit complicated. I'll try to make it as brief as possible. So the telemedicine industry is evolving very fast right now. Probably one of the fastest areas of healthcare IT evolution that we see right now. When telemedicine really started roughly 10 years ago or so, everything was based on proprietary hardware. You had a specific device for one type of function, a specific device for another, and so on and so forth. That is changing rapidly today for many obvious reasons. And think of the corollary to your cell phone, right? I bet everyone on this call right now has some form of a smartphone in their pocket or on their desk, but probably started several years ago, say 7 to 8 years ago, you had a flip phone, right? So you had a flip phone for making calls. You had a calculator for doing complex calculations, and you had a GPS in your car for navigation, right? Now all you need is a smartphone, multifunction. Telemedicine, we are seeing, is going the exact same way, where the hardware is no longer proprietary, and whatever hardware you want to use, it's multifunction. So if you've got an iPad sitting on your desk, you can use that, both if you're the consulting physician or even at bedside with the patient, or at home with the patient, or in the clinic. If you've got a laptop, same thing. Doesn't matter. The telemedicine is evolving rapidly, and what we're going to see is, just like the the flip phone and the BlackBerry are now sitting in museums someplace. It won't be long before we'll see proprietary hardware, robots and so on. They'll be sitting in museums as well, and you just won't even think twice about using your iPad or your laptop.
Thanks, Scott. I think we've got time for one more question. I'd like to direct this one to Bill and Mason, please. And it says, are there any additional steps telemedicine doctors should take to help reduce the risk of medical malpractice liability?
Wow, that's a great question, and it's so great to hear it coming from the provider side. I think I started my career as a med mal defense attorney, and I was responsible for the risk management program, the compliance program at the Medical College of Georgia. So these are subjects dear to my heart, and particularly in the telemedicine space. The good news on telemedicine liability, provider liability and health system liability in the telemedicine space is that we've not seen a great raft of lawsuits growing out of the fact that this is a different kind of encounter. We're aware of one lawsuit, and the standard of care in that northeastern jurisdiction was kept the same as it would be in an ordinary office encounter. I think just like in the way that you manage your clinical practice in an office setting or a clinic setting, you just need to make sure that you have protocols and systems that everyone are oriented to and that are best practices. This is going to sound like a kind of a boring response because, frankly, it's the same old boring stuff. Everyone needs to be on the same page. They need to be educated. Those educational moments need to be updated. You need to be tracking that you've done them, and everyone needs to be in clear communication about what your protocols are. And then it becomes a practice. It just becomes a continuing practice of improvement and monitoring how well you're doing. Much like any other qualitative area of your practice, you just have to monitor it. You have, in the telemedicine space, you already have all the people that you know, your compliance officer, your risk management team, your security officer, the IT department, if you have legal counsel, your office of legal counsel. Once everybody's signed off on what for your institution, and best practices will vary depending on the environment that the specialty that's involved with the encounter and the environment that the encounters are happening in. But everyone needs to be invested in it and buy off on it, and then everyone needs to be educated to it and continuously monitored on it. The other good news I would say is that liability coverage still continues to be very affordable in this area, and it doesn't bring on any untoward pressures, financial pressures to have appropriate coverage. But the best coverage is always to make sure you don't err as you deliver care in this setting.
Bill, thank you so much, and I regret to say that we are out of time. We apologize that we couldn't get to everyone's questions. We answered as many as we could. I'd like to thank our panelists, Scott McLeod, Bill Bowling, and Mason Reed. Great job, guys. And then on behalf of Reach Health, I'd also like to thank the audience for tuning in. We'll be back with more live webinar broadcasts soon, and we've got topics such as the CPC Plus payment model recently announced by CMS as an upcoming topic. Stay tuned. Thanks, everyone.